Hello everyone. We are starting with fibroid uterus clinical features. In last lectures we covered all the salient features, the pathology, what is the definition, but now we will be covering how they present. It is now clinically oriented. Symptoms of fibroid, these 9, either of these 9 or a mixture of these 9 you will find in the patient. Now we need to remember all of them because the question may present that the woman was having 1, 2, 3 symptoms. So the suspicion of fibroid should arise in your mind. Symptoms of fibroid uterus, majority of them, 75% of them are asymptomatic. As we told in the very first lecture that fibroid is a benign growth and it is the most common silent tumor of a female body. So in 75% of case you will not find any symptom and it will be a accidental finding, incidental finding in a scan. The woman underwent a sonography due to some other reason and you will locate a fibroid inside the uterus. But if it presents with symptoms, then the most common symptom is AUB, abnormal uterine bleeding. In the topic of abnormal uterine bleeding, we will be studying everything in detail, but in this pathology, in 30% of cases, you will find menorrhagia and metrorrhagia. What do we mean by menorrhagia, metrorrhagia? Everything I will be discussing in detail. Dysmenorrhea, painful bleeding. Dyspareunia, painful sexual intercourse. Subfertility, decreased fertility. Pressure symptoms over bladder, ureter, rectum. Recurrent pregnancy losses, miscarriage, preterm labor. Lower abdominal pain or pelvic pain, abdominal enlargement. So these are the symptoms that we will be looking for and we will be discussing in detail. What do we understand by menorrhagia? Menorrhagia means heavy bleeding per vaginum. It occurs in 30% of the cases. Most of them are asymptomatic, but if there is symptom, most common is heavy bleeding during periods. It is the classic symptom of a symptomatic fibroid. If the fibroid has started showing you symptoms, then it is the most classic symptom, heavy bleeding PV. It is conspicuous in submucous or interstitial fibroid. You should understand. This is the uterus. If any fibroid is lying over here, that means it is subserous. It will generally not cause any problem with the periods because it is not related to the endometrium at all. But any fibroid which is submucous in location or a big interstitial fibroid which is messing up with your endometrium will cause heavy bleeding PV. Causes of menorrhagia. Interference with the normal uterine contractility due to the interposition of the fibroid. This is such a pathogenesis that we should understand so that we can remember our symptoms well and we can correlate. If we will be given a sonography film in our exam and the location of the fibroid, then we can correlate that which symptom is because of this fibroid and which is not. So this is the uterus and there is a fibroid, right? So normal contractility during menses is like this. So if there is a huge mass over here, it will interfere with the normal contractility and the uterus is not able to control the flow of the periods and there are heavy periods. Congestion and dilatation of the subjacent endometrial venous plexus is caused by the obstruction of the tumor. Congestion and dilatation of the subjacent endometrial venous plexus. The blood supply, the venous plexus is around, what we read in our first menstrual cycle, that the endometrium is richly supplied by blood vessels. Because there is a huge tumor, there is increased supply of blood, and because there is congestion and dilatation, so the amount of periods increase. Endometrial hyperplasia due to hyperestrogenism. This is important. We know that there is something called as anovulation. There are conditions in which the natural menstrual cycle is not occurring and the woman is not ovulating in every cycle. Since she is not ovulating, there is no presence of progesterone. So, no ovulation, no progesterone, unopposed estrogen. There are a list of conditions which are dependent on the hyperestrogenic environment and they increase in size. What are they? One such condition is PCOS, in which there is no ovulation. So, due to any reason, if there is hyperestrogenic environment, then the fibroid, you may find fibroids in these patients. Chances of endometriosis are also high because all of them are hormone dependent conditions. And endometrial hyperplasia, what I talked about in my menstrual cycle lecture, that if the patient is under the effect of unopposed estrogen, endometrial hyperplasia may occur and later on carcinoma may also develop. So, this whole lining become hyperplastic and when it goes out during the menses, there is heavy bleeding PV. Pelvic congestion, because of the presence of huge tumors, there is pelvic congestion which can lead to heavy bleeding PV. Role of prostanoids, there is imbalance in the prostaglandins, thromboxane and prostacyclins. So, there is relatively deficiency of thromboxane, prostacyclin supersedes and there is heavy bleeding, also painful bleeding. Increased surface area of the endometrium. The normal endometrium is only 15 centimeters square. So, if a normal endometrium is shedding off, you will get a normal period 20 to 80 ml. But because of the presence of a fibroid, the total surface area increases. There is a round shaped structure over there. Total surface area increases and the amount of bleeding also increases. So, a fibroid will cause congestion, increased vascular supply. There is some interference with the contractility. There is endometrial hyperplasia. The prostaglandins, they are deranged and in total there is heavy bleeding per vaginum during menses. The next abnormal uterine bleeding symptom was metrorrhagia. What do you understand by metrorrhagia? Metrorrhagia means irregular bleeding PV. Menorrhagia means heavy bleeding PV. Metrorrhagia means irregular bleeding PV. So, what are the causes? Mostly it occurs in cases of submucous fibroids. As I told in my earlier lecture also that submucous fibroid is least in the variety. In subserous, interstitial and submucous, the least common one is submucous, but it is the most common to produce symptoms because it is near the endometrium. So, if there is some ulceration over here, so there is continuously dribbling of blood from this ulceration. The vessels may get torn or there may be some associated endometrial problems, hyperplasia or carcinoma which keep on giving blood slowly every time, every now and then. So, irregular bleeding, the patient may complain that on and off she is having spotting PV. Then your mind should think that there may be some ulcer, there may be some associated pathology. Next comes dysmenorrhea. So, in symptoms we have already read asymptomatic. In symptomatic one, abnormal uterine bleeding, that too menorrhagia and metrorrhagia, heavy bleeding PV, irregular bleeding PV. Now comes dysmenorrhea. Dysmenorrhea means painful bleeding PV. Dysmenorrheas are of two types, congestive and spasmodic. Congestive, as the name suggests, because of the congestion, because of the vascular congestion, there are chances of congestive. This congestive variety causes congestive dysmenorrhea. And spasmodic, because the uterus is acting, it is giving spasm because it wants to expel this foreign body out. What is this tumor? So, it's associated with extrusion of polyp and its expulsion from the uterine cavity. Next comes infertility. Sometimes the patient presents with no other complaints and just say that there is inability to conceive. 30% cases. What could be the reason? Uterine. If the fibroid is here, then what's going on? The ascent of the sperm is problematic. So the distortion and or elongation of the uterine cavity occurs and there is difficult sperm ascent. The sperms which are supposed to go up, it takes lots of time, number one. Number two, if it is a cervical fibroid, there may be some hindrance or obstruction. Number three, the regular rhythmic contractions of the uterus which normally occur to expel the fibroid out, number one, and during normal intercourse which occur for helping the sperm to ascend, both of them are problematic. So they prevent the rhythmic uterine contraction due to the fibroids during the intercourse, and it causes an impairment of the sperm transport. Congestive and dilatation of the venous plexus, so there is defective implantation. Even if there is pregnancy, there is defective implantation. Atrophy and ulceration of the endometrium over the submucous fibroids, it causes a defective nidation. So in toto, either the sperm is not ascending, so there is no fertilization. If there is fertilization, there is no implantation, or if there is implantation, the zygote is not able to survive. Menorrhagia and dyspareunia. Menorrhagia, what I told, and dyspareunia according to the location of the fibroid. If there is a painful sexual intercourse, so there are chances of infertility. Now come tubal causes. It all depends on the location of the fibroid, that what could be a cause and what couldn't be a cause. So what I told earlier also, that if the patient is presenting with some symptom or is asymptomatic, but in the ultrasonography you find a fibroid, the size of the fibroid and the location of the fibroid tells you that what symptoms she could have because of this fibroid. So if the fibroid is located near this place, then there is cornual block. Marked elongation of the tube. If there is a huge fibroid either over here, or it is a broad ligament fibroid and the tube becomes thin, elongated, and the ovary and fallopian tube relationship gets distorted, then there could be a infertility. Associated salpingitis with tubal block. If there is tubal block, then the secretions may be here and it may cause salpingitis, inflammation of the tube. Mainly the tubal factor, it is about the block and the positioning of the fallopian tube and the ovaries. So your patient may be asymptomatic. If there are symptoms, it could be bleeding pattern problems, heavy bleeding, it could be infertility, it could be dysmenorrhea. Other causes of infertility in fibroid, it is associated with anovulation, which we talked about. So if there is a fibroid and the patient says that I am not bleeding regularly, every 2 to 3 months I am bleeding, it could be a case of PCOS, which was already under anovulation, increased estrogen, but now she has presented with fibroid. Peritoneal causes, as I told, remember the chart, anovulation, number 1, fibroid, right? Number 2, endometriosis, and number 3, endometrial hyperplasia. If there is hyperestrogenic environment, please remember these 3 things. You will be happy to know that in every subject, in every topic, either endometriosis or fibroid or PCOS or endometrial hyperplasia, the basic problem is high estrogen. And most of the causes of infertility are not known. Even after removing the fibroid, sometimes the patient don't become pregnant. So we can we can say that these are the theories which cause infertility, but we are not sure that which theory is working in which patient. Now, if your patient is pregnant already, what problems you may encounter during pregnancy and during delivery? So we may counsel our patient that you may go through all these problems, so you should be prepared about it. Number 1, abortion, preterm labor, and IUGR, intrauterine growth restriction. Why? Because if the fibroid is here and the placenta, the area, the placenta gets implanted over here. What happens? The baby is not getting proper nutrition, so there are chances of abortion, or the baby is retarded, the growth is retarded, the baby is small for gestational age. And then there are chances of preterm labor in cases of huge fibroid, because there is less space, and once the space is occupied by the baby, the labor pains start due to the defective implantation of the placenta, and the endometrium is poorly developed. And yes, there is reduced space. Because the space is less, there are chances of IUGR as well as preterm labor. Red degeneration of fibroid, which I already talked about, that during pregnancy there are vascular changes which may cause red degeneration, sudden enlargement, painful pregnancy. Torsion of a subserous pedunculated fibroid. This is very important. There was a pedunculated subserous fibroid and the uterus increases in size. This change in size leads to torsion, or sometimes post delivery when the uterus is decreasing in size. Because of this change in the location, the pedicle undergoes torsion and then it becomes a medical emergency. Labor dystocia. What do we understand by dystocia? Difficult labor. So if in the uterus the fibroid is at this point and the baby wants to come out, it is very difficult. If you are conducting an operative delivery, lower segment cesarean section, and there is a fibroid in the lower segment itself, so operative delivery itself becomes difficult. There are increased chances of operative delivery, definitely, because of if the baby was IUGR, or there was torsion, or there was dystocia, you have to go for operative delivery. And postpartum hemorrhage. Why? Similarly, what we read in menorrhagia, because the uterus cannot contract properly because of the presence of a big tumor. So there are high chances of postpartum hemorrhage. The living ligature of the uterus is not working. She may also present with pain in the lower abdomen. Fibroids are usually painless. So in your case scenarios, if the examiner is saying that the woman with fibroid is having pain, that should arise a suspicion of some complication or some secondary change. Pain is due to the complications like tumor, degeneration, torsion, extrusion, some other pathology, endometriosis or PID. As we say that fibroids per se are painless, but now they are causing pain. So first case scenario which we studied, it was a red degeneration of fibroids, so it was painful. Now torsion, this is the uterus, if it suddenly increases in size because of degeneration, painful. If it was a pedunculated thing and there is torsion, painful. If it was submucous and it is the uterus is trying to expel this out, then again painful. But as I told, because it is a case of anovulation, increased estrogen, so endometriosis will be there. Other things, endometrial hyperplasia, such things may cause pain. Pelvic inflammatory diseases are generally associated with fibroid, so they can cause chronic pelvic pain. Abdominal swelling or lump. Sometimes the fibroid is that big that, and it is, for example, subserous in location and it is a huge fibroid. So the woman would say that I have an enlargement of my tummy, but there is no other symptom. And when you do a per abdomen examination, you find a lump. A fibroid may also present like a lump. Pressure symptoms are rare. Generally, any tumor in the body generally causes pressure symptoms, but because of the location in the abdomen, see, this is the abdomen, and the fibroid is lying here and mostly inside the uterine cavity, it does not cause a pressure symptom. But if it is in the posterior wall, so it will cause pressure on the rectum. So fibroids in the posterior wall may be impacted inside the pelvis, producing constipation because it is impinging on the rectum. Dysuria, urinary bladder is not functioning properly and there is retention of urine. Retention of urine occurs and secondarily it gets infected, so it can cause dysuria. Generally it is not causing any pressure symptom, but if it is causing, it could be impacted in the pelvis and it could be a posterior wall fibroid. A broad ligament fibroid, as we studied in the types of fibroid, It may cause the ureteric compression and it may cause hydroureter, hydronephrosis, changes of pylitis, because back pressure is going, the kidney is not emptying properly, there are changes of pylitis, and there is polycythemia because the kidney secretes the erythropoietin. These were about the symptoms. As we all are knowing, if we are being asked about management of any condition, so the management always starts from symptoms. First I covered the symptoms, it is what the patient tells, right? It is the history part. You have to ask, do you have problem in periods? How long does the period last? Do you have inter-period bleeding? You have to ask dysmenorrhea, do you have pain during your periods? Do you have pain during intercourse? Were you able to conceive naturally, or still are you suffering from subfertility? Is there any problem during peeing, during urination, during emptying your bowel? These are the questions which you have to ask from your patient and have to mention in your long questions. Now come the signs. What you mean a sign? Sign is the examination that you perform as a doctor. Symptom is what the patient is telling, and it is always in the patient's language. And signs are medical language. This is what a doctor is seeing. So we always start with a general examination. How is the look of the patient? If the patient was having anemia because of menorrhagia, she will present with pallor. Now comes the abdominal examination. Per abdomen examination you are seeing, as we know that above the symphysis pubis, if you are able to palpate anything, it is more than 12 to 14 weeks of a pregnant uterine size. 14 weeks or more, the following feature. Now you are able to palpate, there is a lump. What are the features that differentiate it from the other cysts? Number one, the feel is firm, more towards the hard. We need to tell that I am able to palpate a lump. How do we describe a lump? We describe a lump by whether the margins are reached, whether it is well defined or not. What is the feel? It is firm, not hard. Hard means rocky hard. Firm means slightly indentable but not much. So it is generally firm. Hard growths are generally the cancers are hard, and it is a firm feel. It may be cystic in cases of cystic degeneration only, but mostly the feel is firm. The margins are well defined. This is important. That is, the planes are preserved. The margins are well defined. You can locate that yes, there is a 10 by 10 centimeter swelling. Except the lower pole which is not reached. What does that mean? You are doing a per abdomen examination, there is a fibroid, you will say that yes, I can feel this margin, but I cannot feel the lower margin because it is going deep down inside the pelvis behind the symphysis pubis. So only the upper margin is feel, and it is well felt. Surface may be nodular or may be uniformly enlarged. If it is a single round fibroid, it is uniformly enlarged. If it is small, many fibroids, so you will say, oh, knobby, nodular feeling. Mobility is restricted from downward. Like if you try to, like mobility is like left to right mobility is maintained, but you cannot do this mobility in cases of pelvic masses. This is a picture of a bimanual examination or a per vaginal examination. What do? The patient is lying in the lithotomy position. We put one finger inside the vagina and other hand is over the abdomen like this. So we try to palpate our mass between both of the hands. That is why it is called as bimanual examination. So the upper margin is felt by this left hand in the cases of a right-handed person, and the right finger. What all we see? We see the size, right? We see the mobility. We see what is the feeling, whether it is firm or hard. And the last and very important thing, this finger moves this cervix, and we find that the cervical movement is transmitted to the mass. That means this mass is arising from the uterus. So a pelvic examination or a bimanual examination reveals the uterus is irregularly enlarged and the swelling felt per abdomen, as I told you. Uterus is not felt separately from the swelling, and as such there is no groove felt between the mass and the uterus. That means the swelling is arising from the uterus itself. The cervix moves with the movement of the tumor felt per abdomen, and the only exception to these two findings is a subserous pedunculated fibroid. Subserous pedunculated fibroid means it is a subserous thing which is attached with a very small pedicle. So if we will move this thing from the cervix, this movement is not transmitted to the subserous pedunculated fibroid as in case of ovarian masses. So during performing a pervaginal examination, we generally see whether our movements are being transmitted to the mass or not. With this, I finish the symptoms and signs, or in short the clinical features, and in the next lectures we will be studying about the investigation and treatment part of fibroid uterus. Thank you very much.